I was saying, Nancy is moving with her husband to New Hampshire to be with her daughter and her grandkids. So it is a giant, huge loss for us. And as we were brainstorming things to do to be able to signify how much we dearly love, how much she's done with Drug Safe Worthington, and all that good stuff, we brainstorm, and somebody gives a wonderful idea. So I'm going to turn it over really quickly to Bonnie Michael, who is our city councilwoman, who just won yesterday, president of city council. And she has something very special for Nancy.
Come on up here, Nancy. Come on over. First of all, Nancy and I have been neighbors. I lived across the street from Nancy for 27 years.
Just so you're out of that light.
Okay,
So now
all right.
you can take
We've been neighbors for 27 years, and her children babysat for my children. So we have a history that goes way back. And really appreciate, we're going to miss you. The whole community's going to miss you. And so what we decided, we put together a proclamation for you from the city because you're so special and all the wonderful things that you've done and how much we appreciate it. So I'm going to make it a little less boring. I'm not going to say all the whereas. I will just read the starts out the first whereas I'll give. Drug Safe Worthington co-founder and community volunteer Nancy Zajano is preparing to move from the Worthington community to a new home closer to family in New Hampshire. And whereas Nancy has been a passionate leader in the fight against substance abuse, working to bring a coalition of community partners together in a coordinated effort to prevent drug and alcohol abuse and to educate and support individuals and families in the Worthington community. And initiatives such as the Drug Drop Box at the Worthington Division of Police, this Worthington Cares Speakers Series, and other vital educational programs are in place and thriving today because of Nancy's dedication and involvement. And I'll keep the whereases in here. Whereas Nancy was instrumental in helping Drug Safe Worthington win national recognition with the Dose of Prevention Award. And whereas Nancy has been an enthusiastic Worthington supporter who is always willing to participate in community initiatives and projects and encourage others to be involved. And whereas Nancy has made an impactful change to this community, generating and supporting efforts to promote a safe and healthy lifestyle that will continue to enhance the quality of life for future generations. Now therefore I, Bonnie D. Michael, President of the Worthington City Council, do here recognize and thank Nancy Zajano for her underlying dedication to the Worthington community and for leaving a lasting impact for all Worthington residents. I wish her much health and happiness as she moves on to the next phases of her life. In testimony thereof, I have subscribed my name and fixed the seal on the 6th day of November 2019. Bonnie Michael.
That is so touching. I am so appreciative. I can't tell you the privilege it's been to be a part of Drug Safe Worthington, but I also have to acknowledge that the real mover and shaker behind all of this is in the back of the room, Sandy Byers. Sandy was the first chair of Drug Safe Worthington. I have been the secretary. As I like to say, I was behind her taking notes while she led the way. So this proclamation I have to share with Sandy as well. So thank you so much, Bonnie.
You're welcome.
I really appreciate it. I will very much miss Worthington. It's hard to pull up roots of 34 years. And this group has been instrumental in my growth and development and feeling of having purpose and having many wonderful social interactions. So thank you all.
Thank you.
I will say one more thing too. This morning at our coordinating council meeting, everyone agreed that we are going to start a youth council scholarship in Nancy's name that will go to a youth in the district who has been part of the Drug Safe Worthington coordinating council. We're going to set up the criteria for that. That scholarship will go directly to the college, either a 2-year or 4-year college of that student's choice. And we'll have more details on that later, but that's just a little something from us. So I'm going to be greatly missing Nancy. I have learned an enormous amount. I'm hoping Sandy comes back a little bit and helps keep us, so we know the history. We don't want to lose the history of Drug Safe Worthington. So with that said, I'm going to turn it over to Amy to introduce our speaker.
Good evening. Well, my sheet is a description of what our presenter tonight is, but she's got all of her credentials up here. So I just wanted to let you know that Nicole Kwiek co-founded and leads Generation RX, which is a national initiative aimed at promoting awareness of safe medication taking practices and the dangers of prescription drug misuse. She's the director of the Generation RX Laboratory, an educational laboratory here at our co-site here in Columbus, Ohio. She graduated cum laude from Ohio University, earned a PhD in pharmacology from Duke University, and trained as a postdoctoral fellow at the Duke Center for Science Education, and she's also a proud Worthington mom, which I love. So please join me in welcoming our presenter tonight, Nicole Kwiek.
Hi everyone, can you all hear me in the back? Good. I have a loud teacher
You got it, yeah, you got to use that teacher
I'm
voice.
used to talking in big classrooms at OSU. So first off, I just want to thank you so much. It's such a great opportunity to talk to Drug Safe Worthington and get to talk to you about you. I was relaying to some of my dinner mates that in 2011, I've been doing hundreds of these talks for years and years, in 2007. In 2011, we came to Worthington Kilbourne to give a talk to parents, and we had this great program we developed, and we brought in students from the OSU College of Pharmacy, and we were all ready to go, and we had one person showed up. Oh, and we had 10 TV was here to watch it too. So we outnumbered the audience member by quintuple. So this is fantastic. I'm really excited. So thank you all for coming. I'm here today to talk about a couple of things. Generation RX, I'll define it. I'll talk about what that is. It's a word that describes the culture that we live in, but it's also a national outreach initiative that I'll speak to. And then I will talk about prescription drug misuse, because that underlies a lot of the work and the reason why we're here. And then I was asked to talk about the science of addiction. And I'm a pharmacologist, not a pharmacist, so that means I'm a trained scientist. So I love to speak about how drugs are working and understanding how that fits into the broader issue of addiction and drug misuse. So this is meant to be very informal. I have an informal kind of teaching style, and I'm not really teaching here, I'm just sharing. So if at any point you have any questions, feel free to raise your hand. I'm happy to address them in real time. So let's get started, maybe. Okay. All right, so just to lay it all out of what Generation RX. So we are Generation RX. This is not a term that I coined or the College of Pharmacy coined. This was actually, it's like Gen RX or millennials. It describes us as a culture. So across the whole board, we are a medication-taking society, and we expect generally a pill for every ill. In the United States, we have something that's wrong with us, we go to the doctor, we tend to have an expectation that we're going to come away with something to fix it. And usually that's in form of a pharmaceutical medicine. Now, to give scope to that, there are almost 4 billion prescription medications that were dispensed at retail pharmacies. That does not include clinics, that does not include hospitals, so 4 billion is 4 with 9 zeros behind it. It's a lot of medications that we're dealing with each year, and undoubtedly those are helping us to live longer and healthier lives, but when we misuse them, they can have some issues with them. A term that was coined by Greg Kritzer in a book called Generation RX, he talked about, again, this pill for every ill, and then this growing culture of self-diagnosis and self-prescription. So you know this, you've seen this, right? You know that you have some kind of ache or ill, and you think, let me go on Google and figure out what's going on. And then you can go a step further and start to self-prescribe. So maybe your husband has something that has been treated in the past, and so you take it. I've had family members who have adjusted their medication doses because it just seemed too high, right? And that's not, 80 sounded like too much in terms of milligrams. So again, not born out of medical training or medical advice, but this idea that pharmaceutical drugs must be safe to use in any fashion that we can, that they can't be addictive, so I could adjust them and then everything will be fine. Clearly, that's not true. So we know that these medications are helping us to live longer, healthier lives. I come from a college of pharmacy. We're promoting safe medication use all across the board. That's not the issue here. And we want to make sure that patients get the medicines that they need to treat whatever is ailing them. But we want to make sure that people understand that these medications can be just as dangerous and addictive as illicit street drugs. And that was a problem, particularly when they're misused. And that was a problem that we saw when we started Generation RX, this initiative, in 2007. It's right at the start of the opioid epidemic. And we started to hear people say, well, prescription medications can't be addictive because a doctor prescribed it. Or they must be safer than illicit street drugs because they must be, right? So we want to make sure that people understand that there are dangers associated with them. And we define, and the government defines misuse, prescription drug misuse, in 3 ways. And actually a colleague in the at Youth to Youth, which is a youth-led drug prevention organization here in Columbus, had this great moniker or mnemonic device to remember. And it was called more, not for, and just poor. So taking more medicine than you are supposed to, taking reasons taking someone else's prescription medications, so it wasn't for you, and then taking for just poor reasons. So perhaps it was a pain medication to help with a wisdom tooth extraction, but now you're taking these medicines to get high, for instance. So those are the definitions of misuse. You can probably think, even in your own life, in your own house, how you might have misused a medication at one point. Maybe you had leftover medicines from a procedure, and years later you kept it and you said, you know, I think I have that same pain, I'm going to take it again, I'm going to take double the dose because that's really not affecting me. That would all fall under the category of misuse. These ideas and the understanding of misuse, it goes across all populations, all ages. I have a family member who is very well educated, is a school teacher for many years, and we were talking one time and she said, you know, I have this bad cold, and so I decided to take her husband's leftover antibiotics for this cold. And so there, I was thinking about this. I was like, she just knocked off about 3 or 4 of my medication rules right there that she had taken. There with the fact that there were leftover antibiotics, and she took them without a prescription. There were issues. So there's a great need for us to make sure people understand what are safe medication taking practices. When we look at those medicines that are prescription drug classes that are commonly misused, they fall into 3 categories for the most part. And these are prescription medicines, not over-the-counter. So I'm not going to really focus on this, although we do have over-the-counter medicines that are our concern as well. So opioids, the biggest issue that we are seeing and confronting right now, the Vicodin, the OxyContin, the Percocet type drugs. These are used for pain. Stimulant drugs, which are often used for ADD or ADHD. These are the Ritalin and Adderall type of drugs. And then CNS depressants, central nervous system is what that stands for. These are sedatives and tranquilizers. So these include Valium, Xanax that you might be using for anxiety. It also includes muscle relaxants as well as drugs to help with, or medicines to help with sleep disorders or insomnia. So I'm throwing some data out there. I know it's hard to see way back there, and that's not the point. This is more for me to kind of talk about what we're seeing. And this data is coming from what's called the National Survey on Drug Use and Health. It's the big SAMHSA-funded survey that looks at drug use across the country. And so when we look at what people are using in terms of illicit drugs, I should say, and I want to point this out because it's always important to social norm and make sure people understand what is the real number. Almost 81% of people are not misusing or using an illicit drug. So it's important to keep that in mind. Not everyone is doing it. But that's not why we're here. The 20% that are is a major concern. And when we look at, that's 53.2 million people that are using an illicit drug in the past year. So this is based off of 2018 data. If you look at it, the vast majority are using marijuana, but second, third, and whatever that is, sixth or so, seventh, whatever, are prescription drugs. So pain reliever misuse, tranquilizers, sedative misuse, that's one of those CNS depressants, and then the stimulant misuse. So a significant portion of this misuse, or this use, illicit drug use, is coming from misuse of prescription drugs. Yes?
Any idea where alcohol falls on that? Oh, I guess it's right there.
Yep, so this is looking at past year emissions. This is looking at illicit drug use, and I don't think alcohol alcohol doesn't fall into the illicit category, so that's why it was not included on that last graph. I'm not sure what the number is for alcohol. here, but I can talk about the initiatives. So this is talking about how many people newly started using or misusing a drug. So again, alcohol, cigarettes, and marijuana are the top 3. Prescription pain reliever misuse is not far behind though. In fact, it's higher than cigarettes. And then tranquilizer misuse, again, those are going to be your benzodiazepines like the Xanax and Valium type of drugs, and then here's your stimulants. So we're still talking about millions of people who are starting, just in this past year, who have started misusing these prescription medications. Many of you in this room, I'm assuming, have children or have connections to children. That may be why you're here, maybe not. But just to reiterate that, if we're looking at misuse in adolescents, there are a couple of data points that I want to tell. Again, initiates of misuse for these different drug classes in adolescents only come to 850 people per day, opioids, stimulants 500, and CNS depressants 690. These are slightly down. There's encouraging news around the prescription opioids that this is going down, that we're trending down in regards to new initiatives, but the other ones are about the same of where we've been in the past few years. And then I really think this is important for people to understand, particularly if you start to have a judgment about why people are misusing these drugs. It's often done for reasons that are quote unquote good or noble or justified or medical. So if you ask adolescents why they are misusing these medications, they will tell you things like, it's helping to relieve pain. I'm in a lot of pain, this is helping it. So to get high is in there. It's one of the higher reasons, but it's not as high as relieve pain. If we're looking at other things, manage stress, anxiety, increase performance, help with sleep, increase focus, particularly with the stimulant drugs. They're doing it for reasons that they think are perfectly appropriate reasons to use these medications, right? They may not be their medications, but they think that it's not everyone's just trying to get high, and I want to make sure people understand that. They may have a sense of peer pressure, that everyone is doing it. Teens in particular are very concerned about this. One thing that you can remind them is that most people don't misuse. We saw that in that first graph. But even among teens, it's something about 80% of teens aren't misusing medication. So it's important to relay that to your teen that this is not something that everyone is doing. And then they're at a time when they are anticipating to experiment with drugs. And so, in fact, the risk of what could happen if they take these medicines or misuse them is of appeal. And so it's important to note that, particularly as people have very good intentions and they create drug prevention programs that carry on a very scary message that this person almost died because of this incident that happened with their experience with medication or with drugs. Some teens are going to find that to be really compelling to use or to now try that out themselves. So it's important to think that this is a time, natural time, when people experiment in terms of teens, and they might find drug use to be something that is really compelling.
Nicole?
Yeah.
On those studies, were those self-reported rates of use or experimentation, or were those in a controlled study where they were confirmed with UDS?
So for which studies were you talking?
On the rates of use.
So that's a national survey. That's not a longitudinal survey. So that's falling in and then making taking a sample of the country and determining what the widespread use is. So that would be self-reported use. Yeah. Question. Okay. So there are, I mentioned these different drug classes. There is a clear ogre in the room that we should just lay it out there, and that's going to be the opioids. We are in the midst of an opioid epidemic. I'm going to couch a lot of the science of addiction that is going to follow all of this by talking about opioids, because it's the pertinent time too. And I think, but I don't want you to think that that's it. Opioids are the only issue, because you'll see when I come back at the end, there are a lot of troubling data to suggest that the misuse of CNS depressants, for instance, is on the rise, and we could have a new epidemic happening. I hate what this graph says in terms of deaths. This is showing the deaths per 100,000 people from across since the past couple of decades, since 1999. And so you can see this sharp rise. I'm not I'm not happy about the data, but I love what this particular graph tells us. It tells us there were different waves to this particular opioid epidemic. The first coming from those deaths coming about from prescription opioids, and then we had a shift around 2010 over to the heroin overdose deaths. I'm going to explain why that shift happened. It was a very physiological, pharmacological reason why that happened. And then now, as we start to see a surge in synthetic opioids, the fentanyl, carfentanil type of deaths that we're seeing on the street now, that's where we're at and trying to address it. So it's an ogre, we're trying to address it, but it's important for us to understand the science that underlied how we got here. So, I'm going to pose this or frame this as questions that I often have gotten over the years. So no matter what audience I'm looking at, if it's a student, it's a high school student, elementary, they're not usually asking me this question, but I've talked to all kinds of people, and they fall into these different realms. Adults, older adults. So I'm going to walk us through these questions and then answer using the science of addiction to help answer them. So what is an opioid? So an opioid, as you know, or may not know, comes from an opium poppy, so that it has a natural origin. So this is the poppy here. When they're harvesting the natural products from the opium poppy, they slash it with a razor blade type of tool, and then this resin, this sap comes out of the opium poppy, and that's what they actually collect. And that has the bioactive ingredients for opium, or that's opium, and then you can make either natural, synthetic, or semi-synthetic compounds from that natural bioresin. So that's where we get a lot, the heroin, that's where we get the OxyContin or oxycodone. The other types of opioids are derived from this opium poppy. Now, I'm listing up a number of common opioids that you may have heard of. I've given the generic names because I'm a pharmacologist. I don't know brand names very well, so I've given the generic names for the most part. I just want to ask, how many, yell out what you think, how many of these up here are prescription, or actually say medicines? How many do you think are medicines?
All but one.
All but one.
All but one, that is correct, and that is going to be heroin. Heroin
Depends
is the
on
only-
what year you ask.
Yeah,
because one of them
yeah.
was a medication.
Yes, but it's been a while. It's been a long while. And currently, it is not a medicine. It is a Schedule I drug, so it's not currently a medicine. Everything else is. I do want to mention that when you hear about fentanyl and carfentanil in the streets, I need to qualify that. So fentanyl is a medicinal product. But when you're hearing about heroin doses that are cut with fentanyl, that's not coming from a medicinal product. That's coming from an illicit fentanyl that's being synthesized in clandestine labs. So it's an illicit source of fentanyl. Carfentanil is a medication, but does anyone know what that medication is used for?
Animal
Elephant, it's considered a large animal tranquilizer. It's not, so people have said it's an elephant tranquilizer. It is not meant for humans. So you can imagine it doesn't have a purpose for us. It takes a very small amount of this particular drug to elicit a very dangerous effect in humans. Okay, so all of these drugs, or all of these medicines as an opioid, they work in the central nervous system, the brain and spinal cord. And other parts of the body too. They affect neuronal synaptic transmission, and they certainly are useful in alleviating pain. So that's the main reason that we're seeing it. So what do we know about past year opioid misuse? I've shown some data around broad prescription drug misuse, but what do we know? Again, I'll quickly talk about this. So last year, 10.3 million people, 12 and under, misused opioid, used an opioid at some point. 9.9 million people did that via a pain reliever, a prescription pain reliever. So this is a Venn diagram. The vast majority of people who are using opioids are using prescription opioids. Some are using prescription opioids and heroin, and then a smaller number, but still highly concerning. This is 302,000 people with heroin use alone. Again, they might be using other drugs too, but they're using heroin. It's a smaller number here. So, all right, so heroin use only, and then 880,000 people with heroin. That may be that again, some of that overlap. So a lot of people are still using prescription opioids, or misusing them, I should say. Where are they getting these prescription opioids? This is a pie chart. There's two big places that they're getting them. So from doctors' offices. So they may be getting them legitimately from a single doctor because they have an indication for those opioids. So whether that's a legitimate reason or not, indication that is, they're getting them from the doctor's office. So that's what you're seeing over here. Some are coming from prescriptions from one doctor, some are coming from prescriptions from multiple doctors. So about 38% are coming through a healthcare provider. This other big chunk is coming from, given by, brought from, or took from a friend or relative. So I want to make sure you understand one of the easiest ways, that may not be without that friend, relative's understanding or realization that this is happening. That when you have opioid medications in the house, that it is a chance, it's an opportunity for people to access them, even without you knowing. We've heard of these things about real estate tours where people will have an open house and people will go through the medicine cabinets. That certainly has happened. We know that there have been gunpoint type of holdups at people's houses because they know that there are opioids in the home. So it is a liability to have these. Not saying you shouldn't, particularly if you need them, but we'll talk a little bit about how to get rid of them if you need to. Yeah, fine.
I've had the problem where I've had surgery and the doctor says they want to send me home with some of this, and I said, I don't want it. And I was like, well, we can't let you go without it. And I said, well, I don't want the prescription. And then they would not release me until I would take the prescription. And there's something wrong there.
Right.
And if I'm strong enough and I'm fighting it, I feel, what happens to the person that doesn't know? I'm not sure how you educate people to be able to say no, and what happens, or is there someone to report a doctor that wants to push it on you when you don't want it?
Well, we have a system now called that ORS that is useful now in helping us to monitor how opioids are being how lots of medications, but opioids in particular, are being dispensed. So we can identify if a particular prescriber is over prescribing opioids, or if a pharmacist is over dispensing. So that information is out there and helping. It is an issue. You bring up a very good point, and I come from Appalachia. I come from Southeast Ohio, and if you were to talk to my extended family about throwing away perfectly good medicine that was, they could get a 30-day supply for the same price as what they got for 5-day supply, they would think I was crazy, right? This is something that you are throwing something away that potentially could be of utility, and that's hard for a certain amount of the population to deal with. It is important to note, though, you always have the option, if you have a prescription, to not fill the whole amount. So if you get a 30-day prescription, you can say, I would like 3 days of this prescription, and the cost will go down, maybe not substantially based on your copay or whatever, but you can do that. So you don't have to walk away with mounds and mounds of these opioids. Good question, comment on that. Okay, the pharmacology, I love this part. How could a pharmaceutical drug be just as dangerous as an illicit drug or a street drug? So this is where this was predicated, that somehow they must be safer. And I'm not saying, again, if you're taking heroin or you're taking prescription medications as you're supposed to, that the prescription medication isn't safer. I'm talking about when they are misused. When you are taking more than you're supposed to, then we can legitimately say that they can be just as dangerous. And I want to talk a little bit about this. And I mean, how many people in this room really love their chemistry class? Raise your hand. I see a couple. Great. I love my chemistry class. This is good. But the vast majority of you don't, and that's okay. I'm perfectly fine with that. But I want if you can recognize patterns, you're good for what we're going to talk about here. So all drugs, every chemical compound has a three-dimensional shape. So we oftentimes show it as this flat thing against the wall, but that's not how they look. They occupy a space. And that space is important for interacting with what we call receptors and targets and enzymes and other things that are actually doing the stuff in the body. So how this shape dictates whether or not it fits into these receptors to cause the effects. So this is morphine, the structure of morphine. This is what you should see as two-dimensional. And this big, dark wedge is supposed to be just coming out to you. This is supposed to be going back. So again, it takes a little bit of artistic visualization for you to see what this is. But this, I'm hoping, it might indicate it a little better. Let's see if it works. So this is what morphine looks like. Blown up a million times in terms of size, but it has a shape, and you can pick it up and move it around, and again, that shape is going to dictate how it interacts with its target, and that target in the body is a receptor called the opioid receptor. Now, it's important to note that if your body has a receptor, it's suggested that the body has something that it's normally interacting with, right? It's a fascinating thing. Why do we react? Why do we see effects from marijuana? Well, we have a receptor in our body that reacts to marijuana-like compounds in our body. Similar with opioids, we have a receptor, the opioid receptor, that interacts with what we call endorphins, and you probably have heard of endorphins as being these natural pain relievers that you get. It's supposed to help us mediate or deal with pain that we get naturally, or it's a natural way to help with that. Morphine just hijacks that pathway. It just locks onto that same pathway and ramps it up to a higher degree. So here we go. This is the extent of the chemistry you'd have to know. If you look at these three structures, you could probably see that there are some similarities in terms of their structure. They look pretty similar. If we were to group them together, we might say that they all fall into the same drug family. And in fact, that's what they all do. So that's morphine, oxycodone or OxyContin, and then heroin. The body doesn't give a crap whether or not it's called a straight drug or a medicinal drug. It's more worried about how that three-dimensional structure interacts with the receptors. And the body's going to react if it fits and locks in and causes an effect. So this is why we saw that transition in 2010 we rose up, we had a massive amount of prescription pain relievers that were on the market for a whole variety of reasons. Patients had them. And then we clamped down access to those prescription pain relievers. We made it very hard for patients to get them. Well, the body at this point was dependent on opioids, which means it only functions normally in the presence of those drugs, and probably was more likely in a state of addiction, which means that they were in the cravings, the withdrawal symptoms, they were needing that drug, they didn't care about consequences, they needed to fill that opioid space. Well, heroin did that very effectively. There was a surplus of illicit, well, all heroin is illicit, but the black market, black tar heroin that came onto the street this time. Oxycodone at its highest amount was about $80 per pill on the street, and a person who is in a full-fledged substance use disorder would probably need 8-10 pills per day just to address that habit. So you can imagine the financial cost of this. One dose, quote-unquote, dose of heroin was about $15. So it was a very economical fix for how to deal with opioid dependence when the prescription opioids were limited in their access. So that's what happened. That's where we were, and that's where we continue to deal with. The synthetic opioids, the fentanyl, carfentanil, are just a variation on that theme. They're filling this need and doing so at a very it takes very little amount for them to achieve that result. In fact, that's what I want to show you here. Opioids do have different potency. So potency has a real meaning in pharmacology. It refers to the dose that is required to elicit a certain effect. So whatever that effect might be, 50% pain relief, 100% pain relief, whatever it is, it's the dose that achieves that. And some drugs require a very, very small dose to achieve that effect. So if you're looking at pain relief, whatever. If you're looking at a toxicological dose, what will cause you to stop breathing or die, you can have different potencies as well. So this is showing you 3 different lethal doses of opioids. So this is heroin, this is fentanyl, this is carfentanil. It takes an extraordinarily small amount to send someone into an overdose situation with the carfentanil and fentanyl. This is a hazard to the person who might be using these drugs. It's a hazard to people around them who might be helping this person in crisis. It's a serious concern here. We also know that toxicity of the opioids are potentiated. They're increased, they're augmented by a number of different things. If you take alcohol with an opioid, you are a much higher risk of going into respiratory depression and an overdose situation. They are synergistic in that regard. Other medicines, never ever mix a Xanax with alcohol or Valium with alcohol. Same, you should never do that with a Xanax or Valium with an opioid. You get the similar type of synergistic effect on respiratory or breathing that can be lethal. And then alternative routes of administration. We're talking there about how you take in the drug. So did you swallow the pill? Did you crush it up? Did you snort it? Did you take multiple drugs? Or what I should say, did you inject the drug? That the way that you administer a drug can dictate whether or not you are going to proceed into an overdose, or as well as that can dictate whether you become addicted to that drug. So there's, if you are oral administration of drug is a very slow way to get a drug to the brain. Injecting drug is extremely fast, so we find that any time a drug moves into injection, you have a higher chance of becoming addicted. Okay. speaking of addictive, why are opioids addictive? Can't these people just make better decisions? And I want to talk about the disease of addiction and why it is that any type of addictive drug really can hijack decision making in that person. So addiction manifests in the brain. So you can probably guess that this is something that is working on pathways and neurotransmitters and neurons and synapses in the brain. And particularly, all addictive drugs work in what's called the brain's reward pathway. The reward pathway is a fantastic idea. It's really good because we have evolved to have it for a very specific reason. We want to teach somebody to do the right things, right? So tell me some of the natural things that you all do that trigger the reward pathway. So that when that's triggered, you say, oh, that felt really good. So tell me something, natural triggers that are perfectly good for them to activate the reward pathway and your body wants to reinforce them.
PBJ.
PBJ, yes. So food, exactly. Cake, I love it. I could eat cake all day long, every day, right? I love it. It makes me feel good. It tastes really good. It's not good for my health, but it makes me feel good. Food is absolutely a reward. It triggers a reward pathway because the body wants you to continue eating, right? To find joy out of this and continue eating. What else, Mike? What's that?
Sex.
Sex, thank you, right? The body wants to continue to make more of itself, right? To pass your gene pool along, sex is enjoyable for a reason, and because it does activate that reward pathway. Other things.
Praise.
What's that?
Praise? Does that work?
I didn't hear what you said.
Praise.
Praise, yes. Yes, love, nurturing, praise. People have said that when you get likes on social media, that can activate the reward pathway. So yes, absolutely. Anything else?
Exercise.
Exercise. I love when this comes up because I wish that brought me activation of the reward pathway. It doesn't. I have to slog through that to deal with my cake habit. But yes, that is absolutely true. And part of that, you can probably find a very close line to the endorphins that can get released that are natural opioids or opiates that can trigger this. So I love it that sex came up. I have to drag that out of OSU students. They never want to offer that up as a response. So thank you for offering that up right at the front and center. So I should say this reward pathway works in a couple of ways. So there's a thing called the ventral tegmental apparatus that projects to a different part of the brain called the nucleus accumbens, and then this projects up into the prefrontal cortex. Now, this is important. This is mediating that recognition and response into a rewarding substance. And then it projects up into the part of the brain that controls decision making. This is, again, a great design, but when hijacked by drugs, this can be a big problem, right? So it makes sense. Something is good, it makes you feel good, keep doing that. Keep making decisions to keep doing that certain activity. Now, we know that addictive drugs, every single one across the board, illicit, medicinal, whatever, increase activity in the reward pathway. They increase the release of a neurotransmitter called dopamine, and that surge in dopamine tends to give you that feeling of, oh, that felt really good, okay? So everyone, opioids, prescription, illicit, whatever, they cause this surge of dopamine, and what we are learning now is that surge of dopamine helps to train the brain to keep doing that behavior, and then again signal up to the decision-making part of your brain to continue seeking out that stimulus. Opioids, for decades, we've known that they activate this reward pathway. We know that they work in the same areas of the brain. We know that these opioids are addictive, and they cause that brain circuitry to rewire. And that's what I want to make sure you understand. When you just say, why doesn't someone make a different decision, you're asking someone to make a different decision when their decision-making skills have been impacted. It's no longer the same brain that it was pre-exposure to that drug. They have to completely rewire, retrain the brain to make those different decisions. You can, again, coming back to my cake thing, right? I can say every day, I'm going to eat better today. I'm not going to eat cake for breakfast if it's there. And then I wake up and I see that cake and I think, that I want to eat that cake, and so I do, right? Now that urge, that craving that I might have for cake is so minuscule to what someone who is addicted to heroin, for instance, is feeling. They are feeling terrible. Their normal isn't even anybody else's normal. They're taking these drugs to get them back to some sense of normal, but it isn't even their past normal. So I think, I'm saying these things, I'm not trying to be glib that these are equatable, I'm not. But again, we know it's really hard to make decisions that change behaviors, right? And so imagine if your brain is completely rewired to only seek out that drug and find ways to get it, no matter what the consequence is. Leading me to this one, right? Don't tell me this is a disease. And so let me talk to you a little bit about why I can get a bit evangelical that tells you this is certainly a disease and we need to treat it as such if we want to move past this. So I'm going to give you 2 examples. The one on the right is going to depict drug addiction, but the one on the left I'm going to indicate as cardiovascular disease. Anyone want to raise your hands? Does anyone not believe that cardiovascular disease is a disease? Seeing nobody answer. Okay, good. Let's frame this out and I can tell you a little bit about both. So we know any disease, actually most diseases, if not all, have some environmental contribution. It's usually a mix of environmental and other things, but for cardiovascular disease, that eating cake every day for breakfast is not good. That's not a good indicator for my cardiovascular health, right? So diet plays into that. Or how many vegetables are you eating? How much meat are you eating? Saturated fats, all of that kind of stuff. Diet certainly we know has an effect on cardiovascular disease. A sedentary lifestyle, if you are not exercising right, we know that that increases your risk of cardiovascular disease. Having a very stressful job and family life certainly does. And then even using drugs, certain drugs can impact your risk for cardiovascular disease. We know environmental contributions play into the disease of addiction. Exposure to early physical or sexual abuse greatly increases your chance of becoming addicted to a drug later in life. Witnessing violence, especially at a very young age, stress, having peers and friends who use drugs puts you at a higher risk. And then having access, coming back to that idea that we now have tons and tons of prescription opioids that are on the market, going down from where we were 10 years ago, but we have a lot, right? That access of drugs can contribute to whether or not you are going to develop a disease of addiction. Some might say, well wait, someone made the choice, right? Someone made the choice to misuse or to take that drug. Someone made the choice to eat cake and not exercise and have a very stressful job too. Every disease has a component of choice and behavior in it. There are genetic contributions. So again, the things we can't control, right? We were given our DNA, we inherited it, quite literally. We don't have control over this. We know there are gene mutations and polymorphisms that when you have them pass down, I'm just listing a few, I'm not going to get into the science of them. We know that you have an increased risk of cardiovascular disease. We know we have those same genetic contributions for addiction as well. Some of the drugs are involved in drug metabolisms or the opioid receptor, dopamine receptor. You heard me talk about dopamine. Whether or not your reward pathway responds like a quote-unquote normal person to normal levels. If it doesn't, or that can indicate that you are kind of self-medicating with drugs to bring it back up to a normal level. So there are genetic contributions to both of these diseases as well. And then things that we can actually objectively measure, pathophysiological changes that happen with these diseases that we can measure with a fancy instrument or some kind of test, right? So we can look at heart metabolism in a heart disease patient and show objective differences in between how that heart is functioning in a healthy versus an unhealthy state. We can do that in the brain as well. We can see that the brain has different, metabolism in a healthy brain versus one who is an active substance use disorder, right? Objectively, things that we can monitor. And so just as we don't expect, it's not an expectation that when someone comes to the doctor with a cardiovascular disease, and we don't just say, well, you made this choice, you better go fix it, just make some different choices, right? There may be a little bit of that, of how to address the stress and the exercise and all that, but we typically help with medications, right? We give them medications and maybe add 1, 2, 3, whatever it is over the course of time to help keep that disease under control. So So just like we use medicines to treat cardiovascular disease, we can use medicines to treat the disease of addiction. Just to help someone to just make better choices is a really ineffective way to treat disease. So we can use medications to help them with that. And that's the basis for what we call medication-assisted treatment. These are drugs, medicines, that you can offer up to patients with substance use disorder. Some of them are a replacement, so the classic methadone type of drug is what we call a full agonist. And so when you give methadone, it engages that same opioid receptor as a heroin would, and it causes the same kind of effect, but you're doing it in a controlled environment where you're removing the chances that person is taking too much or taking it in ways, the needles that may be dirty, and also increasing your risk for other types of disease risk transmission and other things. We have other things called buprenorphine. So again, this particular drug is interesting. It's called a partial agonist. So that means when this drug, this medicine, interacts with the opioid receptor, it helps, but it doesn't give that full response. And that's important because sometimes that's what you need. You need to help with the withdrawal symptoms that you might be getting from getting off of an illicit opioid, for instance. So this partial agonist will help with that, but it's never going to give that same effect of a high that the heroin might have. Okay? And then another option that people can use, and again, there are, particularly with the buprenorphine and naltrexone, you might have heard of Suboxone that uses this buprenorphine as well as another type of drug in there. Naltrexone is the basis for what we call Vivitrol. These are, again, medications that are used to help patients. Naltrexone is interesting. The way it works is it blocks the receptor. It's called an antagonist. So it causes no activation of the opioid receptor. It's not good at all for helping patients in withdrawal, but it can help patients who may relapse. So this is a long-term injectable where they don't have a choice. It's circulated. It comes in and they have it in for a long period of time. And so if they get back out of whatever facility, they're home, they may be encountering triggers, same social group, same venues where they might have used a drug before, it helps prevent them. If they do use that drug, it's not going to have an effect. And I should say, this is only with opioids. So, all those other drugs, thank goodness we have what I'll talk to you about in a second, the naloxone, that is opioid specific in terms of its ability to reverse. Do I have a solution for if we have a benzodiazepine epidemic? No, and that's scary because we don't have a reversal drug that can help with that. But again, these kind of drugs or medicines are available to patients. We should be opening up access for them to use it. And then, just as we treat patients with compassion, if they're a cardiovascular disease patient, we come in and we work with them, diabetes, whatever, name it. We treat them with compassion. We can do the same with those with addiction. And I'm going to talk a little bit about that even in the language that you use, how you can be a more compassionate supporter of those in recovery or in some form of recovery from substance use disorder. Next question. All right, we're going to pass this opioid epidemic. It's been years, but we're going to get it past it sometime. Then we're good, right? Anyone who knows that and has watched drug use over the decades know that's not going to be the case. This issue extends beyond opioids. On college campuses, we're particularly concerned about stimulants, so the Adderall, Ritalin type of use. That is more rampant there, where they feel a pressure that these to excel and do really well, and they think that these drugs are going to help them focus and do better on those exams. So very concerned about that. Public health-wise, we're also concerned about these benzodiazepines. So again, these are your Xanax and Valium type drugs. We know that benzodiazepine prescribing is a rising concern. If we go back, we're looking here, this is from 2018, it's looking at a heat map of prescribing. If you were to take this same heat map and overlay it with opioids, prescription opioids from 10 years ago, it would be almost identical. We're right on the same level. We also know benzodiazepines, these drugs shouldn't be prescribed for more than a couple of months, and we're finding that the doses are much higher than they should be, as well as patients are on them for months and months at a time. So again, that's a concern, and we know that I already had mentioned these drugs have a natural contraindication, meaning they shouldn't be taken with opioids. When you do take them together, you have a higher risk of overdose deaths. We see these deaths rising as well. Some of these are in combination with the opioids. This is just looking through the years, those number of deaths involving benzodiazepines. But even on their own, if you take out the opioid equation, we're seeing rising deaths from just benzodiazepines alone. So we're not out of the woods yet, and it's important it's important to stay vigilant in this. So, we can get rid of the opioids, but how are you addressing other types of medicines in your house? How are you securing them? How are you making sure that we're not addressing or dealing with a new epidemic in a few years? So what can I do? Okay, good. Just a few things that I think it's important for you to know. Right now, we are in the midst of an opioid epidemic. It is useful for you to know how to address an opioid overdose. You may find this anywhere. This could be in a library, it could be in a school, it could be at your place of work, it could be in your house. It's important you know what that looks like. Typically, a person in opioid overdose is out of it, is the word. They're breathing very shallow. You might even see that their lips might be blue, their fingernails might be blue. They're certainly not able to carry on coherent conversation. Again, the real risk of an opioid overdose is that you stop breathing. So anyway, there's the opioid overdose. It's important for you to know it. The first thing you should do is call 911 and put that person into what we call the recovery position. So that's on their side. Importantly, this allows, if they do vomit, that it allows that to come out of their mouth without choking on it and being affected by that. So put them in the emergency or the recovery position. Is this an emergency situation? Absolutely. And if you are pretty certain, and sometimes even if you aren't so certain, you can administer naloxone. So naloxone is this life-saving drug, and thank goodness we have it. It is one of those antagonist type drugs. It binds to the opioid receptor, and it knocks off that opioid from the receptor, and it doesn't cause an effect, okay? So you can deliver it in different ways. Old school types of things were injections, then they created kind of a misters that you can administer in the nose. They had even a device called Ezio where it talks you through injecting it into the leg. They call this the Lazarus drug because it's been known to, someone coming out looks like they're dead and then they come awake like Lazarus did, so they rise from the dead. It is a very powerful drug. Even if you're uncertain, I mean, there's no harm in administering naloxone. That's important for you to know. So if you know someone who is using opioids, whether that be prescription opioids or whether that be illicit opioids, you should consider carrying naloxone on your person. Just like we learned to carry first aid CPR mask, right? If we knew that we were going to potentially interact with someone who was in respiratory distress, it's the same in this current state. Is very much a Good Samaritan expectation that naloxone could be needed at some point. Secure and or properly dispose of your medications. Get rid of them. If you don't need them, if you have them and you think, I might need them for another day, get rid of them and then ask for them for another day. And usually, I know that's really a privileged statement for someone who has a good insurance plan and doesn't have to pay tons and tons, but it is a liability to have these kind of drugs in your house. So you can have a number of ways to do it. Number one, secure just means even if you're going to keep them, just lock them up, right? You don't, if I think of where I learned safe medication taking practices or didn't learn, right? We kept medicines at home as a kid in the toothpaste area or on the sink, or sometimes they were on the kitchen, right? These are not places. These are places that are very accessible to kids, to dogs, to other people who are in your house. Just think about that. Think about ways that you might be able to secure them. Get them in a place where it's very hard for people to access them. And then, like I said, if you can get rid of them, properly dispose, there are a few options. Every year the DEA offers what we call drug take-back days. We have them in October and April. This is a national event, and certainly Worthington is involved. So you can take your medications, you can hand it over to someone, there's no judgment whatsoever, and you can get rid of mass. I mean, they accumulate tons and tons and tons of these medicines that they take back. You also have the opportunity, it sounds like through Drug Safe Worthington, to drop off your unused medications at the police department. So you, again, no judgment, take them in there, get rid of them. The only thing that we do ask is that you don't put syringes if you have those, as well as don't put loose pills. Keep the pills in some type of connection so that you're not exposing anyone who's emptying that disposal to the medicine. Then there are a couple of other things. So the FDA has some guidelines for how to get rid of medicine. So the first, so these are the ones that we suggest most, right? These are the most environmentally friendly, can get rid of massive amounts of them. If you don't want to wait for that amount of time, don't want to use one of these other mechanisms, you can take your medicines that you're trying to get rid of and take them out of the pill bottle, cross-off, get rid of any identifying information on that pill bottle, add it to something that's unpeeling. We say use kitty litter, coffee grounds, things that someone is gonna take. Now, I should say, people who are in desperate need of finding these drugs will still take them even amidst all of this. But you can try to add as much gross stuff as possible so they don't. You put it in a sealed container, you throw it into the household trash, and then get rid of any, like I said, identifying information. There are a select number, I'm going to say this just so you know, that of medicines that the FDA actually doesn't even want you to risk going through this route, and they want you to flush them. So some of the patches, for instance, they do want you to flush. So just so you're aware, it's not a popular opinion amongst environmentalists, but it is what is recommended by the government for those that are very high risk to patients. And then one of the things that I tend to advocate for is just being a bit more supportive and compassionate about this whole thing. It's very easy in this country, in this state, in the city, all of it, to have judgment about this particular disease. But the words that you use matter, and I'm going to give you some examples on this. Instead of using the term addict or an abuser, right? Abuse is I'm going to talk about that. Abuse is even a fraught word. It has a stigma associated with that. That's why you've heard me talk about misuse quite a bit. It's addict or abuser. That's labeling a person by their illness. We don't talk about Betsy being a diabetic and that's how we lead, right? We don't do that. We talk about Betsy as the wonderful person that she is, and maybe she also is suffering from diabetes. So don't label a person by their illness. It suggests that they're permanently going to be that, and we know that recovery is possible. So alternatives here: person in active addiction, person currently with a substance misuse disorder, or quite simply a patient, right? So those are alternatives to use. Abuse negates addiction as disease. It feeds into this stigma that, when we think of domestic abuse, there's a tie there. So I use misuse, you can say harmful use, problem use, or other alternatives. Using the terms clean or dirty relates the disease of addiction to cleanliness, which we know has nothing to do with it. So, you might say negative, positive, abstinent, substance-free is another way to do it. And then habit is another one that denies that this is a disease. It just seems like just change your habits, right? Go to bed earlier, right? Or just stop taking the drugs. It negates that whole changing of the brain. Implies resolution is a matter of willpower. So talking about it as substance misuse disorder, drug taking disorder, active addiction. These are words that I use to be recovery supportive, and I encourage you to. Even things, I've tried quite hard, and sometimes it's quite hard to do so, but I also don't use imagery that can be triggering to those in recovery. So sometimes it's easy for us to put up images of needles and pills that are in someone's hand, or they're falling, or they're in recovery, they're out because they have overdose. That image is very stark and causes emotional effects, but it also can make someone crave for that experience too, just by seeing that paraphernalia again too. So trying to think about that, how can you help those who are trying to change their behaviors, change this disease, helping support them to do so. Finally, talk to your friends and family. There are fantastic resources on the Partnership for Drug-Free Kids website. There's even a wonderful kind of scenarios of how do you talk to your kids about prescription drug misuse? What do you do if they say this, right? Then you can say this. So there's some really great resources there that you might check out. And then because I'm just that blatant, I'm going to promote this program that I've been involved with since 2007, which is called Generation RX. So we saw quite early that there was a lot of misconceptions about how to safely use medications. People, if you think about your own experience, you were probably never taught in formal school about how to safely take medicines. It's something that somehow along the way you just acquired, and that's a pretty terrible way of trying to get good behaviors instilled. So Generation RX is our website. It's a national, yes, David?
Oh, go ahead, finish
Okay.
what you're saying.
Yeah, Generation RX is a national educational outreach project focused on promoting safe medication taking practices and the dangers of prescription drug misuse. That we have resources all across the lifespan, so we have activities for and resources for youth, K through 5, where we're not talking about addiction and we're not talking about the dangers of drug use. We're talking about what is a medicine. How do you safely use a medicine? Who's a trusted adult that you can ask, that you can presume that you can take a medicine from them? You know, instilling good medication taking behaviors so that if they do see, 10 years down the road an opportunity to misuse a prescription medication, they know the potential dangers of that. We have resources for teens where we do talk about addiction and the implications of prescription drug misuse. We have them for university audiences, adult audiences, patients, so if you are a clinician, we have resources for you, and older adult resources as well. All completely free, all evidence informed, almost evidence based, but evidence informed, which means we're showing that we're using the best practices in drug prevention as well as educational delivery. We're not lecturing to kids, we're using engaging activities for them to learn these concepts. There's our website, generationrx.org. This is, like I said, this started at the OSU College of Pharmacy in 2007. It's now in 115 colleges of pharmacy nationwide. It's reached 2 million people directly through 100,000 facilitators. It's a trainer-trainer type of approach. And then if we look at more environmental impact, it's reached 53 million people. So lots of good stuff that I can help. I would love, as someone who co-founded and currently directed, I would love to connect you to it if you have an educational venue, audience that you can impact with this message.
Nicole?
Yeah, sorry, David.
All right, so we're going at this totally from a pharmacological standpoint. And I lived through an addicted family member who had huge trauma in her younger life, and then had access, because her father was a doctor, to uppers and downers. I knew names of drugs, Percocet, and I mean, well, only as an adult, I finally was able to go back and start to put construct this.
Yep.
But it was the psychological problem.
Yeah.
Because she would put herself in the hospital, almost kill herself, get home, we'd empty out all the drugs out of all the drawers.
Yep.
She'd be okay for a while, and then she would fall into the behaviors, and she ultimately took her life. But it was psychologically,
Yeah.
the damage that she had suffered was always there.
Yeah.
And so I'm wondering, where does that fit into this equation? Because you've kind of, you laid it out as a possible cause, but now we've
Yeah.
gone way past it, but we're not revisiting.
Yeah.
Just getting the person off the drug for the moment,
Right.
or getting drugs out of the house, doesn't fix the problem. Because it's psychological.
Yeah, I appreciate you bringing this up, and I hope I did convey that this drug can be only remedied by giving them more drugs, giving them more medicines, or just telling them to make different decisions. Cognitive behavioral training and interventions are hugely important. And what I tend to advocate for, and what the evidence body literature shows, is that coupling that with medicines that can help a person taper down off of an illicit drug or any type of drug to go substance free is the ideal. And you can't just use medicines to help you. They're going to have to relearn these social situations, how to address the past that force them in some way to confront through the drugs. You have to address that. And what I just want to advocate for is use what the evidence tells us is the best to do, which is this mix of that type of intervention where you're getting at the root cause, you're trying to help them develop skills to get past those, but using the medications to help support that transition. Thank you for bringing that up. This just showcases showcase, and again, the audiences that we have, lots of different, and all of them have a slightly, with our toolkits, they're all free, ready to use, download. They even have kind of talking points, so you can pick them up and go. And then they have slightly different messages. So, like I said, elementary, we're talking about what is a medicine. Teens and university, we're talking about the dangers of misusing. And then our older adult here down in the corner, we're talking about how to safely get the best use of their medication. There's a bit of talk about prescription drug misuse, but are they understanding what a complete medication record is and not using their medicines? They might be taking 5 to 10 medicines at a time. Are they knowing what not to take with those medicines, and how can they leverage their pharmacist as their medication expert in that behavior? And then I'm so happy that David's here as the former CEO of COSI. I want to tell you something that we have in this town that is very, very unique. I can't do this anywhere else when I'm talking around the country, is we have the state-of-the-art pharmacology education laboratory at COSI. So this is a space where you can go completely free of charge with admission to COSI or with your membership. You can go in and you can do hands-on pharmacology experiments to learn about how drugs work with the intent that you're walking away with a message of safe medication taking practice. You're learning one of those rules. So this is some of the people who have come in. They come in through field trips. They come in, we offer shows each afternoon, completely free. We've had people who are 3-year-olds with their 83-year-old great-grandparents with them. So again, I encourage you to make use of this particular special resource. It's the only one of its kind. It's called the Generation RX Laboratory, and it's on the 2nd floor in the Life exhibit. And David was instrumental in getting that Labs and Life space instrumented at COSI. So thank you to him. So with that, this is just a summary. This prescription drug misuse, important contributor to the current opioid epidemic, continues to be a significant public health issue. I talked about why the science backs up that prescription medicines can be just as dangerous and addictive as illicit street drugs. Addiction is a disease that can be successfully treated. We can support that recovery process. And then it's important for you to talk to your friends, family members, as well as model safe medication taking practices. So walk that walk, right? If you're going to say don't keep drugs or massive amounts of these drugs, get rid of them as well. Showcase to your kids that this is how you properly use medicine. This is my lean, mean, estrogen-driven Generation RX team at OSU. So a really fantastic group of scientists, educators, and clinicians. A lot of pharmacists here. We have an evaluator on staff now. Dr. Ruth Emtage is another Worthington resident too. So highly focused on, Worthington has a number of really great people working on drug prevention. So with that, that's all I got, and I'm happy to field any more questions that you have.
Thank you, Nicole. And you've done a great job taking advantage of that opportunity at COSI, so
Yeah.
I can attest that you do fabulous work out of there.
Thank you. I appreciate that.
Does anybody have any questions or anything? Any questions at all? Because now would be the time to ask. So I just want to, let's give Nicole a hand. I do want to point out, the bags that we pass out, the Worthington goodie bags, we do have deterrent pouches in those. So each person who leaves here gets a deterrent pouch, which is really helpful for the medication. And then we did have a big turnout for a drug, that's hard to say, drop-off box that we had a couple Saturdays ago. So we try really hard to promote that through Drug Safe Worthington and everything. But if you get a chance, if you guys could please fill out the evaluation forms. We have extra forms if you did not pick one up. Do you have those, Beth? The extra forms? She's like gonna go grab those. So those are really helpful for us because they give us feedback, know what to change or things like that, things like that. If there's not any questions, I just greatly appreciate you guys coming out. I will say though, our next speaker is going to be Carol Taylor. It will be at Thomas Worthington High School. She's going to speak on how we all need to build resiliency and resiliency in youth. She does a lot of the brain trauma and talks a lot about kids that have trauma and traumatic experiences and how we can help regulate them. And she's going to talk about building resiliency in the youth and in ourselves. So that will be on January 8th, which is our second Wednesday of the month, simply because we are still not back from break on the first Wednesday. Again, that will be at Thomas, same setup, free dinner from 6 to 6:30, and then she'll start about 6:30, 6:45. So, wonderful. Thank you. You guys have a Thanksgiving.